Hello, my name is David Border. I'm an optometrist currently inside the Danville Costco, and I'm working on these educational videos. So far I've done stigmatism, hyperopia, myopia control, and presbyopia, and today I want to concentrate on something a little bit less common, but I think very important. There's a lot of information I'd like to get across about this condition. Don't always have time for that in the exam chair. So today's video is about keratoconus. And for this video, I went all out and put together a slideshow, although most of the information on the slide comes directly from a presentation that a classmate of mine, Angela H. Chen, from Berkeley Optometry, class of 2012. So thank you, Angela. And so keratoconus. So keratoconus is a degeneration of the cornea. So this happens at the cornea. That's the front of the eye here. You have thinning and protrusion at the cornea, and this is usually something that happens in both eyes, although one eye may be worse than the other. About 1 in 700 are the odds of developing for a random person. This starts in teenage years and maybe continues up until about 40 years old. So again, this happens at the cornea. Genetics of this condition, about 50% of people that have keratoconus have at least one close relative with keratoconus. If you have a relative with keratoconus, that increases your risk of developing keratoconus by 15 to 65x. So worst case, you have now a 65 out of 700, or almost a 1 in 10 chance of developing keratoconus. Monozygotic twins are usually both affected. It's autosomal dominant and recessive, several loci located. Other diseases associated with keratoconus, Down syndrome, about 0.5 to 15% of patients with Down syndrome have keratoconus. That represents a 10 to a 300 times increased risk compared to the general population. Interesting, 46% of those patients with keratoconus and Down syndrome have blepharitis. So there may be some reason for them to be rubbing their eyes, itchy eyes, kind of linked to keratoconus. Condition Leber's congenital amaurosis, about 30 to 41% of those patients have keratoconus. And they have the oculodigital sign where patients will rub their eyes for the satisfying experience of seeing little flashes of lights in their vision. And so again, you have eye rubbing associated with this condition. There's also genetics of Leber's congenital amaurosis linking to keratoconus. Other related diseases. So I like to introduce keratoconus in stages of progression for a couple reasons. Not everybody will advance to progress to the advanced stage. Some patients will only remain at the mildest stage, so it makes sense to talk about kind of where we're at now and what may be next. And so that's how we'll go through this. So the early form of keratoconus, also called form fruste or subclinical disease, patients still have 20/20 vision with glasses, and you wouldn't necessarily know that there's any problem if you didn't do advanced testing. So the keratometry readings will appear irregular, and if you're just doing an autorefractor, you'll have normal ranges, normal K readings. And so, for example, most offices will use something like this to measure the shape of your eye. It tells you about the curve of the cornea, and it gives you an estimation of the eyeglass prescription, or an objective reading. And it'll print out the curve, and this will give you typically normal results. If we go back in time to an old school instrument here, this is a keratometer, and with this you can actually see indications of early stage keratoconus. So if you look through the scope here at someone's eye, you'll see regular Meyers, typically, for patients with early stage keratoconus. Rather than these perfectly regular circles, you'll see these distorted, irregular circles that are very difficult to overlap. It's very difficult to get a clean reading on the keratometer. A more modern instrument to measure the topography, or sort of the shape of the cornea, is a corneal topography, and this is what a printout looks like from topography. So if you are looking at these type of printouts with your doctor, you know that you are assessing for cornea disease, including keratoconus. And this is an image that comes from an anterior segment OCT instrument. Here we have the, on the bottom here, the iris. So this eye is looking up, and it's a section through the cornea here, and you can see the thickness of this cornea moving across there, and it looks pretty even. It is thinner in the middle than it is on the edge, but not by a whole lot. So this is a normal OCT of a normal cornea. If we look at keratoconus, you start to see thinning and irregularity here, particularly centrally. Other instruments we could use to assess the cornea and analyze for keratoconus. So keratoconus, that was a mild stage. Now keratoconus can progress. And what you'll see is that the best vision, so you have your eyeglasses and you're not able to see perfect 20/20, not very satisfying endpoint, and maybe your doctor's not able to get the vision any better by adjusting your eyeglasses. So that may be an early indication of keratoconus if you didn't do those extra tests. And what doctors will see in patients is an increase in astigmatism, particularly against the rule astigmatism, or axis 90 or oblique axis astigmatism, keratoconus. You'll see thinning of the cornea before you'll see ectasia. Ectasia is where you have a gradual change to the shape of the cornea. The cornea thins and bulges outward, leading to astigmatism that continues to get worse. So this is an image of, again, the normal cornea on the left, and keratoconus. Not only does it thin, but it has sort of a bulging shape to it. Other signs of keratoconus for the doctor, doing retinoscopy, which is sometimes what we use to measure or assess the shape of the eye for the eyeglass prescription. You'll see an irregular shadowing pattern indicating a regular cylinder. And with this, you can estimate the location of the cone apex and the diameter. And you'll also have, for a dilated pupil when backlit, the oil drop appearance. So you have this appearance coming in, reflecting back onto the front of the eye. You'll have an increased visibility of corneal nerves, as well as opacities of the cornea, superficial and deep. So now, as we move on to moderate and advanced keratoconus, we'll see that the vision is maybe less than 20/20 with glasses, although in patients wearing hard contact lenses, it will usually be 20/20. You have a lot of thinning of the cornea, and from 2 to 8 diopters of regular astigmatism. And irregular astigmatism, if you look at regular astigmatism, the cornea has two curves like the shape of a football, one going up and down, the other going side to side. These are perpendicular to each other. In irregular astigmatism, they are not perpendicular, and also the curvature is not uniform, so you have just an irregular surface. So signs you'll see in moderate and advanced keratoconus: Fleischer's ring, or a hemosiderin arc. This is a circle line around the base of the cone from the accumulation of iron. So this is, you can see here the ring moving all the way around. Fleischer's ring, and Vogt striae, or vertical lines produced by compression of Descemet's membrane. That's a layer of the cornea, and it will disappear with digital pressure. So here you can see these little striations here on the cornea. And as we move to more severe cases of keratoconus, Munson's sign is a V-shaped deformation of the lower eyelid when the eye is looking down. Rizzuto's sign is a bright reflection at the nasal limbus when light is directed to the temporal. So Munson's, they have the pointy or V shape coming from the cone-shaped cornea butting against it. And Rizzuto's, if you have light coming in temporally, it focuses nasally like that. Other signs of severe keratoconus is corneal steepening over 55 diopters, and usually worse than 20/20 vision with contact lenses. 20/25 vision is not considered bad by a lot of standards, but and so a lot of people, a lot of doctors will say, well, you know, it can't be that bad, your vision's really good, but it's really, you know, the overall health of the cornea and other risks and other problems that we're focusing on with this disease. Hydrops is a severe sort of episode you'll have in keratoconus where there's a rupture, breakage in Descemet's membrane, causing a sudden central cornea swelling and a sudden vision loss with significant pain. So again, this is the Descemet's membrane rupture causing edema, fluid leakage into the stroma. Here we have some anterior segment OCT images looking at ruptures and swelling into the cornea. Here you can see a separation with a lot of fluid in there. And here we have some images looking at an eye with hydrops. And so here you can see through the cornea, these cases here, not as well. The edema is very advanced in many of these. So how do we deal or manage keratoconus? Well, in these subclinical or early cases, we'll just wear glasses if that's even needed. In mild to moderate cases, we start with hard contact lenses. Rigid gas permeable hard contact, we prefer a 3-point touch fit. Scleral lenses are becoming a lot more popular, and hybrid lenses are another option where you have the soft skirt. Piggyback fitting where a soft lens is placed on the eye and an RGP on top of that. Contact lens patients often have corneal scarring in keratoconus, so this is pretty bad, but not that uncommon to see some severe scarring on the cornea here when patients are wearing these RGP hard contact lenses. Which brings me to corneal cross-linking as a treatment option. And for this, I'd like to read a summary paper from PubMed. In this book excerpt, there is a nice summary of the ideas I presented here, but I wanted to review this. Treatment of early keratoconus involves prescribing spectacles to improve vision, but as the disease progresses, rigid gas-permeable contact lenses are required. In a small but significant proportion of patients, disease progression may require eventual corneal transplantation. Several new therapeutic options have emerged, including refractive, optical, and lamellar surgery, which slow the progression of the disease and or delay more intensive treatment. Collagen cross-linking with ultraviolet A light and riboflavin is a relatively new treatment that reportedly slows the advancement of the disease in its early stages. So this is something we can consider in the early stages. Corneal cross-linking was introduced to clinical practice in the late 1990s and has since completely modified conservative management of progressive corneal ectasia. Corneal cross-linking utilizes riboflavin as a photosensitizer, which when exposed to longer wavelength UVA induces chemical reactions in the corneal stroma and ultimately results in the formation of covalent bonds between the collagen molecules. This collagen cross-linking increases the tensile strength and rigidity of the cornea, preventing further thinning and ectasia. So this sounds like a very good idea with what we understand about what happens with keratoconus. Silence. And I think some of this I discussed in just the excerpt of the book, but surgery options, keratoplasty, PKP, DLK, that might not be up to date anymore. Intracorneal ring segments or intacts, and laser procedures. So these are all things I would refer you to a cornea specialist to review your options. And that's what I wanted to cover for keratoconus. So thank you for watching the video. Hopefully you get some useful information here, better understanding about how this condition works, and just more of a sense of peace. Hopefully it does not advance for you or your loved ones to these advanced stages, but that does bring me to this link here on this website about living with keratoconus, livingwithkeratoconus.com. And so this is kind of a resource for patients that I think is really nice to be aware of. So thank you for joining me, and have a good day.